Today's topic is placenta and its membrane. So what are the objectives of this presentation is discuss the origin and describe the normal placenta, list the function of placenta, what are the enumerate the placental hormones, discuss any placental abnormality if it is there, describe normal and abnormal things. So what are the fetal membranes? It includes chorion, amnion, yolk sac, allantois, and umbilical cord. Amnion, thin but tough, forms a fluid-filled membranous amniotic sac that surrounds the embryo and fetus, and it is attached to margin of embryonic disc. Amnion, it consists of amniotic membrane, and inside the amniotic cavity there is fluid that is called amniotic fluid produced by amniotic cells, infusion of fluid from the maternal blood, urine output from the fetus, pulmonary secretion, and output is absorbed by the amniotic cells and fetus swallows. Amniotic fluid plays a major role in the fetal growth and development. Daily contribution of fluid from the respiratory tract is about 300 to 400 ml. 500 ml urine is added daily during the late pregnancy. Amniotic fluid volume is 30 ml at 10 week, roughly 350 ml at 20 week, and around its peak 35 to 36 week. What are the different composition of amniotic fluid? It mostly consists 99% is of water, desquamated fetal epithelial cells, organic and inorganic salts, proteins, carbohydrate, fats, enzymes, hormones, meconium, and urine in the late stage. Significance of amniotic fluid: permits symmetrical external growth of embryo and fetus, act as a barrier to infection, permits normal fetal lung development, prevents adherence of amnion to fetus, cushions and protect the embryo and fetus, helps maintain the body temperatures, enables the fetus to move freely. Then comes the another membrane, that is chorion. It is the extraembryonic somatic mesoderm and two layer of trophoblast form the chorion. Chorion forms the wall of chorionic sac. Embryo and its amniotic and yolk sacs are suspended into it by connecting stalk. Chorion. Growth of these extensions are caused by underlying extraembryonic somatic mesoderm, the cellular projections from the primary chorionic villi. This is the diagram showing the extraembryonic and extraembryonic coelom cavity and primary chorionic villi. Chorionic villi cover the entire chorionic sac until the beginning of 8th week. As this sac grows, the villi associated with deciduous capsularis are compressed, reducing the blood supply to them. These villi soon degenerate and form the chorionic villi. As the villi disappears, those associated with deciduous vessels rapidly increase in number and branch profusely. Primary chorionic villi. At the end of 2nd week, the finger-like process formed of outer cytotrophoblast and inner cytotrophoblast appears. Secondary chorionic villi. Early in the 3rd week, the extraembryonic mesoderm extends inside the villi. Tertiary chorionic villi. During the 3rd week, arterial, venule, and capillary develop in the mesenchyma of the villi and join umbilical vessels. By the end of 3rd week, embryonic blood begins to flow slowly through the capillaries in the chorionic villi. Decidua. The cravate endometrium is also known as decidua. It is the functional layer of endometrium in the pregnant woman. This part of endometrium separates from the rest of uterus after parturitions. This separates the part of endometrium separates from the rest of the uterus after parturitions. Decidua is divided into 3 parts: decidua basalis, decidua capsularis, and decidua parietalis. Decidua basalis lies at the site of implantation. It forms the maternal part of the placenta. Deciduous, the full significance of deciduous cells is not understood. They may protect the maternal tissue against the uncontrolled invasion by syncytial trophoblast. Placenta. This is feto-maternal organ. It has two components, that is fetal part. It develops from chorionic sac, chorionic frondosome, and maternal part that is derived from endometrium, functional layer that is deciduous basilis. This is a diagram showing the fetal membrane and placental development in human. During the fourth and fifth month, the decidua forms a number of deciduous septa which projects into the intervillous space. As a result of this septum formation, the placenta is divided into a number of compartments that is called cotyledons. Placenta membrane. This is composite structure that separates the fetal blood from the maternal blood. It has four layers: syncytial trophoblast, cytotrophoblast, connective tissue of villus, endothelium of the capillary. After 20th week, the cytotrophoblast cells disappears and placenta membrane consists only of three layers. It separates fetal from the maternal blood. It prevents mixing of them. It is an incomplete barrier as it only prevents large molecules to pass in, but cannot prevent the passage of virus such as rubella, microorganisms such as Treponema pallidum, drug, and the hormones. Function of placental barrier. First, it prevents most organisms from passing to the fetus, so it acts as a protective mechanism against damaging factor. Many viruses such as rubella, Coxsackie virus, German measles, poliomyelitis virus transfers the placenta. These viruses may result in congenital malformation. Second, most of the drug crosses the placenta and causes the serious damage. Full-term placenta is square in shape. Its diameter is about 15 to 25 centimeter. It is in the center. It is 2 to 3 centimeter thick. Weight is about 500 gram. Umbilical cord mostly is center attached is center or near to the center. The position is in the upper part of the uterine segment, that is 99.5% either in the posterior surface or in the anterior surface. Majority time it is posterior. It has two surfaces. That one is fetal surface, another is maternal surface. In the fetal surface, which is smooth, shiny, because it is covered by amniotic membrane. The umbilical cord is attached centrally to the surface. Maternal surface, which is rough, reddish, it has 15 to 20 elevated area called cotyledons with deep groove in the made of that is called deciduous septa. Function of placenta. Respiratory function, excretory, nutritional, endocrine, barrier function, enzymatic action, immunological function, that is IgG. Nutritive function. Fetal obtains its nutrients from the maternal blood. Glucose transferred to the fetus by facilitated diffusion. Lipids for the fetal growth and development has a dual origin. Amniotic acid are transferred by active transport. Water and electrolytes such as sodium chloride, potassium cross by simple diffusion. Iron and phosphorus cross by active transport. Water soluble vitamin are transferred by active transport, but fat soluble vitamin are transferred slowly. Respiratory function. Although the fetal respiratory movement occur, no active exchange of gas takes place in the lung. Intake of oxygen, output of the carbon dioxide takes place in the simple diffusion across the fetal membrane. Oxygen delivery to the fetus is at the rate of 8 ml per kg, which is achieved by the cord blood flow of the 160 to 120 ml per minute. Excretory function. Waste products from the fetus such as urea, uric acid, creatinine are excreted to the maternal blood by simple diffusion. Barrier functions. Substances with large molecular weight or the size like insulin, heparin are transferred minimally. Only IgG, antibody, and antigen can cross the placenta barrier. Most drugs can cross the placental barrier and some can be teratogenic. Various viruses, bacteria, protozoa can cross the placenta and affect the fetus and yet grow. Immunological function. In spite of one paternally inherited antigen in the fetus and placenta, there is no graft rejection due to immunological protection provided by the placenta. Endothelial and enzymatic function. Placenta secretes various hormone like SCG, human placental lactogen, placental specific beta 1 glycoproteins, pregnancy associated plasma protein, Steroid hormones like estrogen, progesterone. Enzymes secreted are diamine oxidase, which activates circulatory pressure amines, oxygenase, neutralize oxytocin, phospholipase to resynthesize arachidonic acid. This is a diagrammatic picture of placenta in its structure and its function. Placental protein hormones. So there is a long list and it includes SCG, HPL, ACTH, PTH, calcitonin, relaxin, inhibin, activin, ANP. Placental protein hormones. They are hypothalamic like releasing and inhibiting hormone. TRH, GnRH, CRH, GHRH, fetal compartment alpha beta proteins, maternal compartment prolactin, relaxin, and other decidual proteins. Human chorionic gonadotropins, the glycoprotein with biological activity similar to luteinizing hormone, both act via plasma membrane luteinizing hormone SCG receptor produced in the placenta but also synthesized in the fetal kidney. Number of fetal tissue may produce beta subunit or intact SCG molecule, also produced by malignant tumor. Presence of SCG in the blood and urine of reproductive age. Women is also indicated of presence of fetal trophoblast either in the pregnancy or neoplastic disease. Chemical characteristic of SCG. It is a glycoprotein, carbohydrate component, and plasma life is about 36 hours. 2 units, alpha and beta, no biological active other separate subunit. Bioactivity brings after binding to the LH receptor combined as a 2 unit, structure identical to other glycoprotein like SLH, FSH, and TSH. Amino acid sequence of beta subunit SCG distinctly similar from the LH, FSH, and TSH. Biosynthesis of SCG plasma level it reaches its peak at 36 and plateaus till the end of pregnancy, roughly correspond with the placental mass. Activin stimulates and inhibin inhibits its production. Less than 5 weeks, SCG expressed in both in situ and cytotrophoblast cells. SCG later on is only produced by in situ trophoblast. Concentration of SCG in serum and urine. It's a peak in the 7 to 9. Intact SCG molecule develop in the 7 to 9 days after ovulation. Blood level doubles every 48 hours. Maximum level attained about 9 weeks. Between to 60 to 80 days after the last menses, peak level reaches about 1 lakh international unit per liter. Concentration of SCG in serum when SCG titer exceeds 1,500 in TVS, intrauterine gestation sac should be identified. Its peak is about 10 to 12 week gestation, then it reaches its below nadir about 20 week. Plasma level are maintained at the lower level for the rest of the pregnancy. Urine concentration SCG follows the pattern of the maternal plasma. So this is a diagram in which the peak of the SCG is attained around 8 to 10 weeks, that is 9 weeks. Then it tapers sharply and reaches to at a low level and continued in the same plateau level till the term. And the estrogen progesterone level rises as it reaches the nadir and they reaches at peak around 30 to 36 weeks. SCG in urine follows the same curve as the plasma SCG. Metabolic clearance of SCG is 30% through the kidney, rest cleared by the liver and other pathways. Biological function. It is initially produced for the maintenance and rescue of the corpus luteum. Up to there is a, then after there is a shift that is called corpus luteal placenta shift. Under when the placenta start forming and takeover is happens. Stimulation of fetal testicular cells. SCG helps in that also. Before 110 days, no fetal pituitary LH is there. Critical time sexual differentiation happens. SCG enter in the fetal plasma by from the in situ trophoblast, act as a LH surge and stimulate the replication of testicular Leydig cells and testicular synthesis, and which help in the male sexual differentiation of tissues. Biological function of SCG, stimulation of maternal thyroid. SCG also bind with the TSH receptor because it has similar structure, similar subunits. Promotion of the relaxin secretion by corpus luteum promotes uterine vascular vasodilation, myometrius smooth muscles relaxation via LHF. SCG receptors suppress maternal immune function, reduces the possibility of fetus immune rejection. Human chorionic maternal SCG or placental lactation structure similar to growth hormone produced by the placenta. Level through the pregnancy, large amount in the blood, maternal blood, but do not reach the fetus. HPL is a GS-like activity. The chromosome is chromosome 17. Serum concentration, it starts within 5 to 10 days after conception and reaches up to the peak around 34 to 36 weeks. Regulation of HPL biosynthesis stimulated by insulin, inhibited by PGE2, F2 alpha. Metabolic action are lipolysis and act as the anti-insulin action. Human chorionic somatotropin SCG, essential lactogen. Biological effects are reverse of those of insulin. HCS level refers to placental size. So placental steroid hormone, there are various progesterone, estrogen, different forms of estrogen, estrone, estradiol, estetrol. All reaches to peak near the term. Progesterone after 6 to 7 weeks, their production is minimal. After 8 weeks, placenta replaces ovary and source of progesterone continues to increase production throughout the pregnancy. Synthesized from the cholesterol in two-step enzymatic reaction. Limited capacity of biosynthetic cholesterol in the trophoblast. Trophoblast preferentially uses LDL. Source of cholesterol for placental progesterone biosynthesis. Hydrolysis of LDL releases the amino acid cholesterol ester. Progesterone and fetal well-being. No relationship between placental progesterone synthesis and fetal well-being. Progesterone biosynthesis may persist several weeks after fetal death. Progesterone metabolism during pregnancy. Same as man in non-pregnant women. During pregnancy, the disproportionate increase in plasma concentration of 5-alpha dihydroprogesterone as a result of synthesis in the in situ trophoblast from the placenta and derived progesterone and fetal derived precursor. 5-alpha reduced metabolite contribute to resistance in the pregnancy against the vasopressor. Prepares and maintain the endometrium to allow implantation, has a role in suppressing the maternal immunological response to fetal antigen, serve as a substrate for fetal adrenal gland production, supports of endometrium to provide an environment conducive in fetal survival, suppression of contractility in uterine smooth muscles. Progesterone potentially inhibits secretion of pituitary gonadotropics like LH and FSH. This effect almost always prevent ovulation during pregnancy. Placental estrogen production, it's a produce huge amount of estrogen. Normal human pregnancy is hyperestrogenic state. First 2 to 4 week rising level of SCG maintain production of estradiol. 7th week of the maintain maternal corpus luteum production of both progesterone and estrogen decreases. Luteal placental shift is there. 7 week more than 50% estrogen entered from produced from the placenta. Placental estrogen biosynthesis is mainly pathway estrogen synthesis from the placenta differ from the ovary. Production occurs in the follicular and luteal over thicker cell synthesize. The two of the principal effect the placenta estrogen stimulates growth of the myometrium, antagonize the myometrium suppressing activity, stimulates mammary gland development. Then comes the relaxin hormone. So it is expressed in the human corpus luteum, deciduum, and placenta. Then comes the leptin, is normally secreted by adipocytes. Inhibin, it is also a glycoprotein. In which pituitary FSH release produced by testes, ovarian granulosa cells, and the corpus luteum. Inhibited by activin A, stimulated by SCG GnRH, may by GnRH to regulate SCG synthesis and secretion in the placenta. Activin closely related to inhibin enhance FSH synthesis and secretion, participate in the regulation of menstrual cycle. Activin also chorionic activin and inhibin regulate within the placenta for production of GnRH, SCG, and steroid. Feto-maternal circulation. It includes two umbilical cord and one umbilical vein. Umbilical arteries, deoxygenated blood or venous-like blood flowing into umbilical vein with the specially higher oxygen content, 80% saturation. As the fetal lung are not functioning in the antenatal time, fetus obtain its oxygen nutrients through the umbilical cord. The core concept behind the fetal circulation is the fetal hemoglobin, which has a higher affinity toward the oxygen than the adult hemoglobin. Circulatory system of the mother is not directly connected to the lung. Water, glucose, amino acid, vitamins, inorganic salts freely diffuse across the placenta along with oxygen. Circulation. Blood from the placenta is carried to fetus by umbilical vein. About half of the enters the fetal ductus venosus and is carried to IVC, while the other half enters the liver proper, inferior border of liver, the branch of umbilical vein, and supplies the right lobe of liver first joined with the portal vein. Blood then moves to the right atrium of the heart. Between the right and left atrium, the foramen will allow most of the blood flow through it directly into the left atrium from the right atrium, thus bypassing pulmonary circulation. The continuum of this blood flow is into the left ventricle is from there, which is formed through the aorta in the body. Some of the blood entering the right atrium does not pass it directly to the left atrium through the foramen, but enters the right ventricle is formed into the pulmonary artery. In the fetus, the connection between the pulmonary artery and aorta is called ductus arteriosus, which directs most of the blood away from the fluid-free, non-functioning lung. Changes in the fetal circulation at birth. Closure of umbilical artery functionally soon after birth, and its obliterate it takes 2 to 3 months further structurally. Closure of umbilical little later than the artery allows extra amount of blood go to the fetus from the placenta. Closure of ductus arteriosus within few hours of respiration. Closure of foramen functionally soon after birth, but anatomically it takes longer time, up to 1 year. Changes of fetal circulation at birth. Fetal structure and internal development. So, foramen oval in the intrauterine life, fossa ovalis in later on, ductus arteris changed to ligamentum arteriosus, left umbilical vein, partly ligamentum teres, partly ligamentum venosum, left and right umbilical artery, proximal portion superior vesical artery, and distal portion medial umbilical ligament. Abnormality of placenta. So as you can see, it can be abnormal in shape, size, diameter, weight, position, adhesions, form. Abnormality of placenta, abnormal position. It could be placenta previa. The placenta is attached to the lower uterine segment due to low level of implantation of the blastocyst. It causes severe antepartum hemorrhage. They are theta. Total placenta previa, where the entire internal os is covered by the placenta. Abnormal adhesion. It could be creta, where simply adhered chorionic villi go inside the abnormal adhesion between chorionic villi and the uterine wall. Placenta percreta. The chorionic villi penetrate the myometrium all the way to the perimetrium. Placenta fail to separate from the uterus after birth and may cause severe PH. Abnormal attachment of umbilical cord. It could be filamentous attachment, that is, cord does not reach the placenta itself, but it is attached to the amniotic membrane over the fetal surface of placenta. The umbilical vessels passes in the membrane to reach the placenta. It is easily torn. Abnormal shape. Placenta could be bilobate, bipartite, placenta succinturate, placenta circumvallent, placenta fenestrosis. So on the basis of shape, it could be of 5 types. Placenta bilobate. Here you can see in the image there are two lobes and placenta is equal to lobes connected by the placental tissue. Placenta bipartite. Placenta consists of two equal parts connected by the membranes. The umbilical cord is inserted in the bun of the lobe and branch from its vessel across the membrane to the other lobe. Rarely, the umbilical cord divides into two branches, each supplies a lobe. Placenta succinturate. Placenta here consists of large lobe and smaller lobe that is unequal in size, connecting one another by the membrane. The umbilical cord is inserted into the larger lobe and branch of its vessel crosses the membrane to reach the smaller succinturate, that is accessory lobe. Accessory lobe may be retained in the uterus after delivery of the leading to the post pH. There is suspected if a circular large gap is seen in the membrane from which the blood vessel passes through the edge of placenta. Placenta circumvallate. A whitish ring is composed of decidua is seen around the placenta from its fetal surface. This may result when the chorion producum is too small or nutrition of the fetus so peripheral villi grow in such a way, splitting the decidua visalis into superficial layer, that is whitish ring, and deep layer. Placenta circumvallate. As the fold of fetal membrane is seen, an exposed area of fetal surface along with the cord is seen. It can cause abortion, antepartum hemorrhage, preterm labor, and IUFT. Placenta fenestrata. A gap is seen in the placenta covered by membrane, giving appearance of a window. On the basis of abnormal diameter, the placenta membranous, a great part of chorion develop into placental tissue. The placenta is large, thin, and may be 30 to 40 centimeter in diameter. It may approach the lower uterine segment, resulting in placenta previa. And if it is separated early before the delivery of baby, result into the abruptio placentae, that is antepartum hemorrhage. The umbilical cord. Anatomy is developed from the connecting star. At term, it measures about 50 centimeter and its diameter at term is 2 centimeter. The umbilical cord structure consists of mesodermal connective tissue called Waters jelly covered by the amnion. It contains one umbilical vein, carries oxygenated blood from the placenta to the fetus, and two umbilical arteries carry deoxygenated blood from the fetus to the placenta. Remnants of yolk sac and allantois. Umbilical cord insertion. The cord is inserted in the fetal surface of the placenta near to its center. Not exactly in the center, but near. So if the placement is called eccentric insertion, that is 70%. Or at the center, if it is there, then central insertion, that is 30%. What are the different abnormalities of umbilical cord? Here we see there is marginal insertion. On the basis of insertion could be in the margin and it is called better door insertion, and velamentous insertion in the membrane and vessels connect the cord to the edge of placenta. If these vessels pass at the region of intercourse, the condition is called vasa previa. Vasa previa can occur also when the vessel connecting a succinturate lobe with the main placenta passes at the region of internal os. The velamentous insertion of the cord at the membrane and vessels travel through the membrane to reach the main placenta. And if it is near the internals, then vasa previa occurs and bleeding from the genital tract is mainly through the fetus, not from the placenta. Abnormal cord length, the short cord which may lead to intrapartum hemorrhage due to placental suppression of placenta, delayed descent of fetus during labor, and inversion of uterus. Abnormal cord length if it is long, then cord presentation, cord prolapse, coiling entanglement of the cord, true knots, leading to fetal distress, sometimes fetal death also. True knot, when the fetus passing through the loop of cord, if it is pulled tight, fetal asphyxia may result. False knot is a localized correction of the Watten's jelly containing the loop of umbilical vessels. Here is no harm to the vessels, so no fetal asphyxia is seen. Long umbilical cord may more easily be twisted or even form a knot. That is the picture showing the true knot, where tightening of the knot causes fetal asphyxia, and fetus may result into IUFT. Thank you.